Hi, I'm Mike Schiff, and I'd like to talk to you about something that I think you'll see in your office and your clinic in the near future, and that's subcutaneous abatacept. And I'd like to share with you the development program of subcutaneous abatacept. So abatacept really had to ask a number of questions in their development. The first question was whether or not subcutaneous abatacept worked, and I'll share this data with you on this slide. The second question is whether it was equivalent or non-inferior to IV abatacept. And another question, obviously, was whether or not one could start and stop subcutaneous abatacept, like we have to do with patients in the clinic for multiple reasons, without immunogenicity concerns and being able to recapture our patients using subcutaneous abatacept. On this slide, we see the original phase 3 trial data. This was a open-label trial with subcutaneous abatacept at 125 milligrams subcutaneously once per week, which will be the dose of subcutaneous abatacept. A number of questions were asked. One was the short-term efficacy. The second question was, do you need methotrexate with subcutaneous abatacept for efficacy? And then the last question was, what does the long-term extension data and the long-term information for efficacy and safety look like on subcutaneous abatacept? So one can see on the bar graph here at 4 months, abatacept in the orange plus placebo methotrexate, or abatacept plus methotrexate in the green bar, gave approximately a 50% response rate for developing low disease activity, again a high hurdle that we'd like to see in our patients, and that was at 4 months. If one then looks at the 18-month or the long-term extension data from this original trial, one sees about a 60 to 70% response rate in this group of patients. And again, very similar responses for subcutaneous abatacept, either with or without methotrexate. Important in this trial were the safety pieces of information. There were only 4 bacterial serious infectious episodes, so there was not a lot of serious infections. The injection site reactions for subcutaneous abatacept were very low, approximately 2%, and none of the patients really had to discontinue because of this. They all occurred and were mild in the first 4 months of the trial. The next question, which is a major question, and that is the non-inferiority of the currently available IV abatacept versus subcutaneous abatacept. And this is a very large trial presented at the ACR meeting, looking at almost 700 patients per arm, and patients were given either IV abatacept or subcutaneous abatacept. And the question was asked, obviously, what is the efficacy and what are the toxicity issues in these 2 arms? If you look at the graph on the right side of the slide, you can see the ACR response rates, with very significant ACR response rates for ACR 50, 70, and obviously the ACR 20 response rate. But if you look at the dotted lines versus the solid lines, i.e. the subcutaneous versus the IV, they really just fall exactly on each other with equivalency or non-inferiority. And again, when data was looked at for safety, injection site reactions in the subcutaneous group was about 2%, similar to the previous trial that I showed you, and not really different than the placebo group, because they were getting placebo injections of subcutaneous AB in the IV group at 2.5%. Serious infectious rate was about 1% in both groups, so again, not a major issue and very important to us as clinical rheumatologists, and limited autoantibody production. And again, the summary from this I think we can take home is that intravenous abatacept versus subcutaneous abatacept looked very similar. 2 other questions arise as clinicians. If we have a patient who currently is on IV abatacept and is doing very well, can we switch that patient to subcutaneous abatacept? And that was addressed in a trial that was called the ATTUNE trial, and one sees the data on this graph on the right side. So patients were entered into this trial who were in the AIM trial or in the ATTAIN trial, that's the methotrexate incomplete responders, or the TNF incomplete responders. And then they were switched from IV to subcutaneous. And you can see from this graph, really no significant decrease, maybe even a bit of an increase in their efficacy for a DAS remission in these patients doing well. And then lastly, the ARROW trial summarized on the bottom right, where there was a start and a stop and then a restart of subcutaneous abatacept. This trial did show that the patients were able to be recaptured and that the antibodies were not a significant issue, and we were able to switch our patients. Thank you, and I think I'll open this up now for questions.
An interesting presentation, and obviously sub-Q ABA is going to be a viable medication, I would think. Do you think it's going to be used before anti-TNFs now, or do you think it's going to remain where it is? Is the sub-Q preparation going to change the use?
Well, I think that if one looks in the U.S. market versus the worldwide market, there may be a different answer to your question. But in the U.S. market, I think that having the availability of a sub-Q abatacept will probably increase the use of abatacept in our patients with rheumatoid arthritis.
So Mike, I think it's very clear what you had to say. Do you think now that basically you've convinced me that sub-Q and IV are essentially equivalent, do you think sub-Q is going to start to be used first rather than IV?
I think many of us as clinicians and our patients are pushed by our healthcare coverage. As you mentioned just before, in the world, IV use and IV utilization of drugs has decreased because of the cost. Subcutaneous therapies have grown because of the savings in costs, as we've heard from NICE, we've heard from the German authorities, and I'm sure we will hear from the folks in Washington as well. So I do think that this does bring up the fact that we could switch our patients if we need to from IV to sub-Q, or we can initiate sub-Q abatacept in patients for rheumatoid arthritis.